تمام. تمام، أهلا وسهلا بالدكتور سلمان. اليوم عندنا محاضرة بعنوان Review of Critical Care Management of Acute Ischemic Stroke. راح يقدمها الدكتور سلمان الجردي Assistant Professor of Neurology Weill Cornell Medicine Qatar Consultant Stroke Neurology in Hamad Medical Corporation. Dr. Salman, welcome. You can start.
Thank you very much دكتور إبراهيم. السلام عليكم جميعا. وطبعا يعني يؤسفنا أنه نكون عم نلتقي بظروف مثل ما هالظروف، والله يرحم الشهداء والله يحمي الناجين بإخواننا بتركيا وأهلنا بسوريا. إن شاء الله يا رب أنه تنتهي الأمور ويكون اللي صار وما يستمر بإذن الله تعالى. وإن شاء الله أنه الموضوع اليوم ولو أنه مرة تانية بالإنجليزي، وأنا بعتذر ما كنت عارف أنه لازم يكون بالعربي. هو it will cover بإذن الله تعالى concepts ممكن نستعملها نحن to care for patients with neurotrauma اللي ممكن يجي عندهم ضربات بالرأس مما يؤدي إلى سريبرال الإديمة وما إلى ذلك. فبليز بالأخير إذا في أسئلة عن هذا الموضوع أنا طبعا جاهز للمساعدة بأي شكل بإذن الله تعالى. فخليني أبدأ وبعدين بنجاوب على الأسئلة بالنهاية بعتقد مثل ما حكينا أول. فإذا اليوم راح نتحدث عن النيورو انتنسيف كير، العناية المركزة العصبية، وراح نتحدث شوي عن النيورو كريتيكال كير، what it is, الهيستوري اوف نيورو كريتيكال كير، الامباكت او الاثر تبع نيورو كريتيكال كير، وبعدين نتوجه للحديث عن الكريتيكال كير مانجمنت اوف ischemic stroke in specific. In particular, we will focus, inshallah, on ischemic stroke. We will cover the following topics, which we will discuss, inshallah, in greater detail as the lecture continues. فإذا بالأول, we can begin with what is neurocritical care. التعريف تبع neurocritical care من صفحة الفellowship training تبعهم is the intensive care management of patients with life-threatening neurological أو neurosurgical illnesses. طبعا في overlap. It provides the interface between the brain and the other organs in the body in the setting of critical illness. Usually these are combined in one ICU. Well, ICU is focused on delivering the care for this critically ill patient. طبعا because this is a new field, the training is very different around the world. فأنا with my experience بالUnited States و in the context of SAMS طبعا you can achieve neurocritical care certification بالUnited States بأمريكا from these specialties من neurology, neurological surgery, حتى internal medicine. They will do training in pulmonary critical care أولاً, and then they will do training in ICU for neurology. Anesthesiology can do this, surgery can do SICU, بعدين neuro ICU, emergency medicine. وطبعاً pediatrics has a new field called pediatric neurocritical care. This is only, I believe, maybe 4 or 5 hospitals in the United States. These are physicians who can handle diseases of critical care of the body, including cardiac arrest, respiratory failure, or sepsis, or kidney injury, وما إلى ذلك, in addition to critical neurologic and neurosurgical disease. In the US, there is more than 70, I think هلا صار في حتى يمكن 80 fellowship programs for training for neurointensive care. Most of the time it is 2 years for training, but if you are in neurosurgery, it is 1 year for training for neurocritical care. What are the conditions which are treated by neurocritical care? طبعا the first one is cerebrovascular disease, which we will focus on today, but there is really an array of conditions that is addressed by these patients, by these physicians. It includes anything from trauma, which of course in the context of an earthquake is very relevant, في seizures, neuromuscular disease, infections, يعني it goes all the way to the end. And then there is general critical care issues. So you will see this is يعني general, it covers cardiac, pulmonary, renal, hematology, and things like this as they relate to patients with neurologic disease. The field is also very procedural. I think in general people don't think of neurologists as physicians who do procedures, but this is an example of the procedures that are expected to be completed by a neuro-intensivist or neurocritical care physician after completing fellowship training. طبعا some of them are very simple, يعني central venous catheter placement أو mechanical ventilation or BiPAP or endotracheal intubation, but some of them are more complicated or are more focused specifically on neurocritical care. مثلا intracranial transcranial Doppler, طبعا Dr. Maher is a world authority on this. There is other things like ICP management, pressure monitors, EEG interpretation. So really it encompasses this vast group of procedures, both for general critical care and specific for neurointensive care. So how did this begin? يعني what's the history for this? In the 50s, in the 1950s, تقريبا من 70 سنة كان في epidemic of polio. Almost 70 years from the COVID pandemic, there was a polio epidemic. Actually, it was epidemic. So I think if there was air travel back then in the 50s, like there is now, this would easily be a big pandemic with several deaths with disability and things like this. But in polio, because of the paralysis and the neuromuscular weakness it produces, caused an increase in demand for muscular support of lungs, يعني basically ventilatory support. So this created a need to develop respiratory units. As a result of this, these two gentlemen, Dr. Bendixen and Dr. Pontoppidan, both of them are actually from Denmark. They're both Danish, but they were both working in Boston, Mass General Hospital. This is Harvard's largest teaching hospital. They established the first respiratory care unit in the 1950s. But then almost 20 years after, so it took quite a long time, but in 20 years later, most large hospitals in the United States, some in Europe, some in Asia, but mostly in the US, عندهم كان ICU. ما كان في MICU, TICU, SICU, PICU, it was just ICU. And then afterwards, this طبعا divided into different specialties of intensive care. Specifically, when we focus on neurocritical care, the field in the very beginning was driven by neurological surgery. وطبعا with the development of anesthesia in the 1880s and the 1900s, the surgeons were able to perform more complicated procedures. But of course, more complicated procedures means post-operative care for these patients becomes very complex. For Dr. Dandy, are you familiar with the Dandy-Walker malformation and things like this? So Dr. Dandy, who's actually a neurosurgeon at Hopkins, basically created the first neuroscience intensive care unit in 1932. And this is before the polio pandemic. This was not a respiratory unit specifically. This was a unit just generally focused on the care of patients with neurological disease, specifically surgical illness. Almost 20 years later, London, كان في عندهم شيء اسمه Institute of Neurology and National Hospital for Nervous Diseases. They created something called the Batten Respiratory Unit. طبعا I think you're familiar with Batten disease from the pediatric neurology. All these patients are mainly created for people with neuromuscular diseases, such as with Batten. But of course, because of the availability of these and the polio beginning, patients with spinal cord trauma and neurovascular disease were added to Batten's respiratory illness. So this was basically considered the first neuro ICU in Europe. From this day on, more and more ICUs opened, and the field really has been driven not just by neurosurgeons, but also really by ingenuity on the nursing side, where nurses have developed nursing science and nursing care to accommodate the patients that are in the neuro ICU. هلا طيب, we talked about neurosurgery, we talked about nurses, وين النيورولوجي, وين الستروك والامور هاي. فالنيورولوجيsts actually and I remember when I was a medical student, many people would say, neurology is diagnose and then you don't do anything, diagnose and adios. But طبعا this has changed significantly over the past decades. Particularly speaking, neurologists became interested in acute care and acute neurologic disease, specifically coma, after CPR became very common. So لما صار في CPR, people were receiving CPR, this became something very widespread. Neurologists were asked to come and give kind of a prognosis, to prognosticate for patients who underwent cardiac arrest. This brought neurology into the acute setting, into the emergency setting. عادة هنا they were more focused on the chronic illness and things like this. Specifically, في work by Fred Plum مثلا. If you're familiar with Plum and Posner, the diagnosis of stupor and coma. Raymond Adams طبعا from the famous Adams, I think Adams was at Harvard. C. Miller Fisher is a Canadian neurologist. برضه نقل على Mass General and he practiced at Harvard. These guys really, they led the field in fundamental work to develop the understanding of coma and the understanding of the neuroscience behind coma. Fred Plum was chair at Cornell in New York where I practiced. In the 1980s, with the expansion of neuroscience ICUs, because now they were growing, we needed coverage. يعني you have units, but you don't have enough physicians. Interestingly, neurologists were actually staffing a lot of these units, but they did not have ventilatory training or critical care training. But with support from anesthesia, they learned how to provide care for these critically ill patients independently, يعني without the help from anesthesia. And this continued to drive the field. There was more research, more increase in publications, until finally in 2004, the Society for Neurocritical Care was established. Now this is a recognized subspecialty of neurology under the American Board of Psychiatry and Neurology in the United States. طيب, what's the impact of this? يعني okay, عملنا neuro ICU, so what? يعني طبعا the impact of critical care in general is difficult to measure specifically because critical care is very complicated. But I think we can begin by exploring the different parts of neurocritical care. So قلنا إنه physicians as well as the nurses have to be experts at providing general and neurologic critical care for these patients. But the ICU is more than just doctor and nurse. There's a lot of people, particularly in large hospitals and big ICUs, that practice in the ICU. أولاً مثلاً respiratory therapy. This is very common. This is very common in the ICU. Why is this relevant? Why do these people have to be more familiar with critical care for neurologic disease? مثلا, if you have a patient who has an acute stroke, it's very big. We'll talk about this later today, inshallah. And you have them to be desaturated. One of the things that we can do to increase the patient's saturation is to increase FiO2, increase inhaled oxygen. But the other thing is to increase PEEP, اللي هو peak and expiratory pressure على الفنتليتر. PEEP increases intrathoracic pressure. ولما نزيد intrathoracic pressure, it actually decreases the venous drainage, both from the body and from the head into the chest, which results in a decrease in the drainage of the blood من الvenous system from the brain. It results in increased intracranial pressure, worsening herniation potentially. يعني something as simple as giving people oxygen can actually worsen intracranial pressure. Pharmacists have to be very familiar with side effects تبع medications تبعهم when it comes to the central nervous system and peripheral nervous system. مثلا, a lot of us will use antibiotics to treat infections. صح? For example, cephalosporins, يعني مثلا cefepime is used very commonly. This is a 4th generation cephalosporin. It turns out cefepime will result in decrease in seizure threshold. والناس اللي عندهم مثلا meningitis that are coming in with infection, بيصير معهم sepsis, and you give them cefepime, it increases their confusion. It actually can result in them having more seizures من status epilepticus تبعهم. في antibiotics مثلا we have to avoid in people with myasthenia because they tend to worsen myasthenia. There are antibiotics that we cannot use مع warfarin because they interact with warfarin or vitamin K cycle. It results in very different INRs. So يعني we have to have pharmacists who are very comfortable with medications طبعا. The social workers طبعا We see this more in Western societies because of health insurance or things like this. بس برضو هن they have to be very familiar with the specific needs of their patients. يعني إذا عندك patient with heart failure بتبعتهم على البيت وبتعطيهم شوية ليسكس you know they're fine يعني وبتخلي معهم حدا. بس ال neurological patients are different. ما بيقدروا يتحمموا, they may forget their medication, they may have severe depression, they may have personality change from frontal lobe stroke مثلا, or bleeding or trauma. It can result in divorce. يعني social workers have to be very familiar with these very complicated patients and عندهم الصراحة very complicated needs. So لما يكون ال critical care is so complicated, it's very difficult to say إنه يعني there is an impact. بس people have tried. مثلا بسنة 2011 there was this paper published in a neurocritical care journal. Do neurocritical care units save lives? Well, actually this was a systematic review and meta-analysis. It looked at I think 11 studies if we count, in patients who either had TBI or intracerebral hemorrhage or subarachnoid hemorrhage or ischemic stroke. It compared whether the team in ICU اللي the patients were admitted to, did it have a neurointensivist or did it not have a neurointensivist? Well, basically they looked at functional outcomes for these patients اللي هو مثلا Glasgow outcome score. If we look at the outcome اللي هو death, this is the names of the studies. This is the name of the outcome, which in this case is death. We look at the patients who had neurocritical care units versus people that did not. وطبعا the p-value here is extremely significant. And as you can see, mashallah, excuse me, if you add up all of the numbers, it is very clear and patients who have neurocritical care actually have much lower risk of death compared to patients who do not have a neurocritical care unit. نفس الشيء if we look at favorable outcome in general, this was many ways defined by the Glasgow outcome scale, which is يعني similar للmodified Rankin scale, but not really. It just measures an outcome تبع patients. Again, patients with neurocritical care versus no neurocritical care, هون the p-value is 0. It's even smaller than الأول. يعني very clearly there is an impact on these patients. طيب بتقولوا لي هاي paper in the neurocritical care journal أكيد يعني بدها تطلع positive. Here's another one برضو من نفس الجورنال برضو in 2011, the impact of dedicated neurocritical care team in treating patients with subarachnoid hemorrhage. Okay. وطبعا مثل ما كلنا بنقرا البيبرز بنروح على الكونكلوجن بالابستراكت. The implementation of neurointensivist-led neurocritical care team is associated with improved hospital discharge for patients. يعني إذا عندك patient راح مع subarachnoid hemorrhage على neuro ICU, they are more likely to have a better discharge to a better place, يعني more likely to go home أو to rehab than مثلا لا سمح الله to die إذا كان في neuro ICU. طيب هاي paper من 2016 يعني it's newer. It is from the Journal of Critical Care يعني مش تبعنا. This is the General Critical Care. برضو it looked at subarachnoid hemorrhage وبرضو it looked at the same question. Clearly it found إنه the patients who were managed in a neuro ICU had improved neurological outcomes. So يعني I hope إنه I have convinced you إنه this is actually helpful for patients. So this is something perhaps in the future بالوطن العربي and in many parts of the world it is worth investing money in with resources with training لأنه it seems to have a real impact on the outcome تبع patients اللي عندهم neurologic disease. Specifically اليوم بإذن الله we will focus هلا more specifically on ischemic stroke. وراح نتحدث عن critical care of these patients. يعني مش أي patient with ischemic stroke, the patients who really need ICU care. And we will discuss airway, we will discuss blood pressure, cerebral edema, يعني swelling, we will discuss hemorrhagic transformation, early recurrence, progression, and some other issues. This will be شوي detailed discussion, بس إن شاء الله we will be done in time to take questions. فمين ischemic stroke patients اللي ممكن يستفيدوا من النيورو اي سي يو؟ يعني not everyone who enters into the hospital with an ischemic stroke needs to be in the ICU. But really there is 3 general rules The first rule is if your patient needs hemodynamic or respiratory support, يعني they need to be on a ventilator, ولا their blood pressure is low, بدك تعطيهم pressors, generally these patients need to be in ICU. إذا patients عندهم يعني very severe stroke, or you really need to monitor them very closely, vital signs parameters, وعطيتهم TPA or something like this, أحيانا عدد النيرسز اللي على الفلور ما بيكفي. You need to put these patients in the neuro ICU لأنه على الفلور بيكون مثلا في one nurse بيكون عنده 4 patients 5 patients 6 patients ما فيها تفوت كل ساعة لعند البيشنت and review how are they doing وإذا it's very hard. بالICU عادة بتكون one nurse ل one patient أو one nurse ل 2 patients or something. بيكونوا عندهم وقت أكتر, they have more training or more familiarity with people with critical illness. الشيء الثالث طبعا which is the most scary, we'll talk about this اليوم, is if they have مثلا hemorrhagic transformation, if they have cerebral edema, or if they have any complications specifically من acute stroke. So let's begin. أول شيء airway management and ventilatory support. So مين بيحتاج الintubation? Who needs endotracheal tube or ventilatory support? طبعا the very basic, this is true for all of medicine, مش بس بالنيورو ICU. People who have either failure of oxygenation, يعني they have desaturation, or people who have failure of ventilation, يعني their carbon dioxide is increasing in the blood. طبعا this can cause CO2 narcosis, so this can cause people to become somnolent, or this has its own problems. The other type of people who require intubation are people who are not able to protect their airway. صح؟ يعني مش بس إنه lungs لازم تشتغل, كمان لازم الزروب, airway also has to be able to work. Usually, if they are not awake enough, يعني إذا GCS تبعهم Glasgow Coma Scale is less than 8, they usually require intubation. أو إذا عندهم impaired oropharyngeal function, يعني their muscles in their oropharynx are not able to contract properly or be open properly. ومثلا an example of this is people that have Wallenberg syndrome, lateral medullary syndrome. They have paralysis of the vocal cords, some of the muscles in the back. Well, these people can have severe aspiration وما إلى ذلك. So any of these patients, typically they will need intubation. If there is aspiration, let's say your patient has oropharyngeal dysfunction, or the patient مثلا is too sleepy, or it results in aspiration. How do we prevent this? طبعا بالأول, don't give your patient any medication ولا شيء by mouth, NPO, لحد ما they pass the swallow evaluation. احنا بنعمل a test to see if they are able to swallow. أول شيء بنعطيهم some kind of solid food, يعني خبز أو شيء يبلعوه, we watch their swallowing ومتأكد إنه ما بيتشردوا, it doesn't get stuck. They're able to have a good coordination of swallow muscles. But then we give them liquids. So people اللي عندهم dysphagia because of non-neurologic illness, يعني مثلا they have a tumor in the esophagus, or they have throat cancer or something, typically they have problems swallowing solids. But patients that have neurogenic problems of swallowing, they will typically be able to swallow solids easier, but the liquids will be more difficult, and liquids require more coordination to control. The other thing we should do, the patients اللي انت you're suspicious انه maybe these patients will have aspiration, keep their head of the bed elevated, يعني خلي the head of the bed 15 degrees 30 degrees, so إلى حد ما you are trying to protect these patients from aspirating. طيب حدث الاسبريشن صار. What do we do? What's the therapeutic? The preventative measures did not succeed. Now the patient has aspirated. In the beginning, إذا بس نزل عنده شوية saliva or something like this, they can develop fever. But most of the time it's just chemical pneumonitis. You don't need to do much. يعني إذا blood culture تبعك negative والwhite blood cells seem to be okay, بس البيشنت يعني هذا spike of fever وبعدين رجع على fine, I think it's okay to be conservative. But if you really suspect there is a pneumonia, you see مثلا تعمل X-ray, you see right lower lobe infiltrate, في مثلا strep is growing in the blood, أو عندك مثلا mixed flora from the saliva, then you become more concerned وتستعمل antibiotics, and because it's aspiration you have to cover for anaerobic and aerobic bacteria, يعني مثلا augmentin something. You intubated the patient, you treated their pneumonia. Now it's time to talk about extubation. Who do we extubate? مين the patients اللي eventually they can be extubated versus patients that cannot be extubated. So generally لأنه الستروك patients ما بيكون عندهم lung problems، بيكون عندهم airway problems. These airway problems typically improve. Most patients do not require long-term intubation. Usually بيكون محتاجين بس short-term intubation. والbest predictor يعني بعد كم يوم لما يصير الجلاسكو كوما scale above 8 بالstroke of anterior circulation or above 6 in posterior circulation, this usually predicts إنه الpatient can be extubated. فيك تشيل التيوب. هلا إذا أعطيتهم 4 commands the patients were able to follow all 4 commands, this is even more reassuring من the Glasgow Coma scale إنه there will be a successful extubation for this patient. لأنه it tells you إنه these patients are awake, so they're able to follow commands. معناته they are probably able to protect their air. طيب, in patients who fail extubation, you cannot extubate. Tracheostomy is fine. يعني these people will be okay. بالعكس نحن we want you to put a tracheostomy tube لأنه it allows them to go بيطلعوا من المستشفى ويروحوا على الريهاب. والريهاب is very important طبعا for patients' functional recovery, especially in the early few days after stroke. طبعا the data suggests إنه أول 24 hours you should not do physical therapy, but after 24 hours you should introduce physical therapy. فنحن we think it's very very beneficial to introduce physical therapy as soon as possible after 24 hours. There is a large number of patients تقريبا الثلث اللي بيكون عندهم hemicrania بيكون محتاجين tracheostomy. The timing is unclear, يعني مش واضح if you're supposed to wait 7 days or 10 days. And I think you have to see how your patient is doing, decide based on your experience, your expertise with patient. Blood pressure. Blood pressure is a big topic. We can have a whole lecture on blood pressure alone, but this is the basic understanding of blood pressure management in the ICU. I think all of you are familiar with this. This is called the autoregulation, cerebral autoregulation diagram. لما يكون blood pressure, طبعا in this case this is the map, اللي هو mean arterial pressure, أقل من 50. الفيسلز بتكون صارت كتير كبيرة already وبصير ينزل blood flow to the brain. It becomes less and less and less. This results in ischemia and infarction in the brain. لما يكون between 50 and 150, these blood vessel changes بتصير blood vessel بيصير يصغر, يعني it becomes narrower and narrower and narrower. This allows for the blood to remain stable when it comes to flow لحد نقطة معينة وبعدين the brain loses the ability to shrink blood vessels even more وبيصير في too much flow again, and this causes vasogenic edema و other issues in the brain. فطبعا نحن we want to be in this zone. لما يكون في stroke, الستروك مش بس بتأثر على المخ, الستروك بتأثر على البلد فيسلز اللي بتروح على المخ, واللي بيصير بدل ما تكون البلد فيسلز دايناميك وبتقدر انه تغير حجمها بداية من التشينجز ان بلد بريشر, بيصير شكلها بهالطريقة. It looks like this. It doesn't really change, it doesn't really give you a nice stable range to address blood pressure. I see إنه في بعض participants raising their hand. I will get to your question بإذن الله تعالى, but let me finish إن شاء الله. I will go back in the slides to answer your question. Thank you very much for your understanding. I appreciate it. يعني طبعا this has a real impact on the blood pressure and on the outcome of stroke patients in particular. In general, patients اللي بيكون عندهم stroke patients have high blood pressure. This is reflex, this is normal. We want to see patients come in with higher blood pressures لما يكون عندهم stroke. لأنه there is data showing إنه if the patient comes in وعندهم big stroke والblood pressure تبعهم واطي, this is really للأسف associated with poor outcomes because of failure of collateral circulation to the area of the ischemia. ولكن برضو we don't want the blood pressure to be too high. We agreed يعني سبحان الله إنه 220 systolic pressure is the upper number. يعني a lot of people say 120 is the diastolic number. هذا الرقم is chosen at random بصراحة arbitrary. فيعني you don't have to wait until they get to 220. بس يعني 200, 210, it's okay to think about treating them. Unless عندهم, they have some reason you want to use lower blood pressures. يعني مثلا a patient who has an aneurysm من قبل, أو a patient who has congestive heart failure, أو pulmonary edema, أو acute kidney injury, أو retinal injury. So you monitor these patients. إذا عندهم أي سبب إنك تنزل أو إنك تنزل blood pressure أكتر, then this is something that you should consider. So sometimes you are stuck in the opposite situation. في بعض المرضى بيكونوا very dependent on their blood pressure. يعني if they have a decrease in blood pressure, their exam becomes worse, their blood pressure goes up, their exam improves. This can happen يا إما بيكون الأوكلوجن is partial, يعني بيكون في بعد شوي من البلد vessel مفتوح, أو بيكون عندهم collateral circulation but it's not fully developed. So these people usually need we induce their hypertension. We can use مثلا IV fluids. Typically people use 0.9% sodium chloride, يعني نوع saline. أو أحيانا نستعمل vasopressors. أكثر شيء بنستعمل هو phenylephrine, مع إنه you can use norepinephrine as well in these patients. وفي بعض studies, they were very small case series يعني, بس it showed that these patients actually had better outcome if you improved their blood pressure. Not everybody should have very high blood pressure. صح? يعني if we give patients TPA, their blood pressure should be less than 185 over 110. This is from the original NINDS study in 1995. And after they receive IV TPA, the number is actually less. يعني we decrease by 5. So from 185 to 180, 110 to 105. Now طبعا with the development and availability of mechanical thrombectomy in some cases, we don't know if we should lower the blood pressure even further. Some people say 160, some people say more, but there is new data showing that too much lowering of blood pressure is too bad. This tells us the physiology is more complicated than just opening a blood vessel. You can use any medication. يعني أنا personally, I like to use labetalol. You can give them IV 10 or 20 milligrams. You can keep repeating labetalol, بس تطلعوا على heart rate. Make sure it doesn't drop below 60. يعني 60, 55, I think you have to stop. إذا عندك heart rate already low, you can use hydralazine 10 milligrams IV. This typically will drop their blood pressure. وفي بعض الأحيان we will use nicardipine اللي هو calcium channel blocker, just continuous drip. طبعا اللابيتالول والهيدرالازين أسرع, يعني they start quicker, بس لأنه البولس بينزل البلد بريشر بعدين ممكن يطلع. فالنيكارديبين يعني is a drip, you can adjust the dose to allow them to continue. وفي there are other medications, esmolol or other things that you can use. طيب, cerebral edema, this is the big one. People are very scared of swelling with cerebral edema. Initially, patients can come in وعندهم يكون stroke, normal MCA stroke, but in less than 10% of these patients, it can become malignant. It becomes very strong, it becomes swollen significantly, extremely enlarged. ومع انه اقل من 10% من الناس بيصير عندهم هالموضوع, المورتاليتي, الdeath from this is higher than 50%. This is very serious. This is something that we have to focus on. مين الاشخاص اللي عندهم احتماليه اكثر انه يصير عندهم المشكله هاي؟ الناس اللي صغار بالعمر, young age, لانه بيكون حجم المخ بعده كبير. طبعا مع كبر السن بيصير قيمه المخ اكثر, بس للاسف صغار السن حجم المخ اكبر, سبحان الله. اللي عندهم very big stroke, يعني حسب ما نحن بنقيسها بالNIH stroke scale, more than 20, او اذا كانت على non dominant side mostly on the right, more than 15. اذا عنده nausea او vomiting بأول 24 ساعة is a very very concerning finding. أو إذا بيضل blood pressure تبعهم عالي بأول 12 ساعة. إذا هني when they arrive they already have impaired consciousness, or the CT already looks bad, or more than one blood vessel is involved, or there's a big infarct volume. يعني these are the risk factors for people that will likely become more sick when it comes to acute stroke. So people ask, طيب, if I'm worried about swelling or cerebral edema, should I monitor intracranial pressure? الحقيقة يعني routine monitoring is not indicated الصراحة. We don't typically do it. في ناس they're very aggressive, يعني دغري بيحطوا bolt, بس truly you can look at the patient to examine the patient and you will have a decent idea about their intracranial pressure. على عكس مثلا patients with traumatic brain injury مثل بالearthquake المخ تبعهم بيكون swelling is more general rather than specific. It's harder to tell based on their exam إذا عندهم increased ICP or not. These people you are more recommended to do routine monitoring on these patients. طبعا in the future I think more and more stroke patients might be monitored, especially if we use something called multi-modality monitoring. يعني they put catheters بالمونيتور نفسه بيسموهم microdialysis catheters بيصيروا يقيسوا lactate و pyruvate و they can kind of tell if there is more ischemia or less ischemia. يعني if a catheter only gives you information about pressure it may not be helpful, بس إذا بتعطينا biochemical information ساعتها ممكن the risk of drilling the skull or putting the catheter in is justified in these patients. basic principle يعني شو بنعمل نخفف الانتراكرينيال بريشر اللي هو الاي سي بي. في اشياء بسيطه وفي اشياء that are more complicated. مثلا بالاول الهيد اوف ذا بيد اتليست يكون 30 درجه 30 ديجريز راسه للشخص مرتفع. هذا بخلي الدم يبلش ينزل اكثر من الراس على السيركيلاتوري سيستم. head position midline يعني الراس ما يكون على اليمين او على اليسار. remember how the patients are weak, so they will typically tilt their head on one side and they will occlude the internal jugular, بيسكر internal jugular, so then they are only using one to drain. So try your best to keep them open. Adequate temperature control, no fever, لأنه fever increases brain metabolism which increases blood going to the brain which increases intracranial pressure. نفس الشيء مع pain. With pain, people typically they reflexively يعني valsalva and this increases the pressure inside the head. نفس الشيء مع الباول regimen. إذا يعني nobody thinks الصراحة إنه I have a patient with a stroke بدي أعطيه يعني باول regimen وبدي أعطيه مثلا docusate أو Senocot أو شيء. بس if these people strain to go to the bathroom this will increase their intracranial pressure. طبعا we talked in the beginning about mechanical ventilation, peak and expiratory pressure, how this increases intrathoracic pressure. حتى there is a recommendation to avoid using the femoral arteries when it comes to access to the femoral veins, internal jugular veins. Use the subclavian, طبعا pay attention to pneumothorax. We use the femoral مع إنه it's less clean, but we want to keep the jugulars open to allow for blood to return to the chest. Some people talk about hyperosmolar therapy, يعني mannitol, hypertonic saline. If you are trained in Europe, I think you use hyperosmolar therapy much less frequently. If you are trained in North America, you will use this very often. I'm trained in the USA, and I use this all the time. But I recognize, the data is not very strong. Really, there is a difference in opinion. But what we all agree on is avoid hyponatremia at all costs. يعني hyponatremia is very bad. I think 135 is the limit below. وحتى أنا I love to keep the sodium above 140 to avoid swelling or increasing the brain swelling. طبعا the idea of using hyperosmolar therapy is to increase the osmolality تبع السيرم ونسحب الفلويد من البرين ونحطه بالبلاد vessels وبعدين through diuresis we can excrete this into the urine. في ناس they use continuous مثلا بيحطوا 2% or 3% saline and they just keep it going or they follow a sodium target. Or there are other hospitals that use intermittent bolusing. يعني إذا monitoring showed ICP elevation or a patient becomes sleepy أو نزل الأوزمولاليتي أو نزل الصوديوم. It seems like retrospectively intermittent administration يعني as needed is more helpful than continuous. لأنه with continuous hyperosmolar state بنفقد الجريدينت اللي هو بين البرين وبين البلد vessel, so we cannot really pull fluid anymore from the brain. So how do we use them? There are many ways to use them. طبعا mannitol is relatively standard. The dose تبعه is 1 gram per kilogram. بنحط solution 20%, يعني بتكون 20% of actual mannitol. You can give this every 6 hours. Remember, this is renally excreted. It's a big diuretic, so make sure they don't have an AKI. You cannot give it to them as an osmolality gap أكتر من 10. وهاي الإيكويشن to calculate الosmolality gap إذا بتحطوها على التليفون it will do it for you إن شاء الله. الhypertonic saline, there are many ways to use it. You can use 2%, 3%, 7.5%, 23.4%. نحن بالدوحة honestly we don't use 23.4% very often. بأمريكا أنا I use this very often. هي بتكون بس 30 ملي you inject it to the patient, central access. You can really see the difference in intracranial pressure when you do it. We don't usually give it to patients لما الصوديوم يصير أكتر من 160 بيصير عندهم مثل diabetes insipidus مثل nephrogenic DI. والمشكلة إنه you should use this with central access, وأحيانا it gives them a lot of fluid إذا كانت مثلا 2 or 3%. فممكن إذا عندهم heart failure you can give them pulmonary edema. You have to pay attention to this. طيب إذا all of these medical treatments ما نفعوا, really the idea is to look at surgery. وبالsurgery decompressive hemicraniectomy is really the most common procedure that we use. في procedures تاني ممكن نستعملها. يعني إذا كان في كتير swelling أحيانا some of you from your experience you will see and we will do hemicrany, بعدين the patient will continue to have cerebral edema. These patients can undergo مثلا temporal lobectomy من the brain that's already dead. But the standard really is this. Basically the summary of this is the Destiny 2 trial. And if your patient is older than 60, you should offer them decompressive hemicraniectomy as a life-saving measure. But if they are less than 60, they are within first 48 hours, يعني أول يومين, you should really offer them the surgery because it improves their outcome in the case that they are younger than 60. We're almost done. Management of hemorrhagic transformation. طبعا patients with stroke, whether they receive TPA or not, they can have hemorrhagic transformation. Actually, بالoriginal study تبع NINDS that approved TPA, the patient who had the largest hemorrhagic transformation كان واحد بالplacebo group. So really this can happen without TPA. It tends to happen in patients with cardioembolic stroke من الAFib or something like this. فنحن we have a scale. There are several scales, but يعني this is the most common. HI1, HI2, PH1, PH2. PH2 this is the only bad one really. How do يعني they're not so bad. But PH2 is the big one, which results in a problem with outcomes of the patients. So if you see significant hemorrhagic transformation, يعني PH2, you react based on what situation you're in. يعني if you have a hemorrhage أقل من 24 ساعة من TPA, the recommendation إنك تستعمل شيء اسمه cryoprecipitate, وممكن تقيس level of fibrinogen in the blood بعد الكرايو. وإذا كان under 100 you can still give more cryoprecipitate to get the fibrinogen to be on target. في شيء اسمه fibrinogen concentrate, بس it's not really frequently available in many places. طيب إذا البيشنت عنده elevated INR مثلا بياخد warfarin or something else, في شيء اسمه 4-factor PCC اللي هو prothrombin complex concentrate. This will really reverse the INR very quickly. في كمان شيء اسمه fresh frozen plasma which you can use. بس the fresh frozen plasma is huge. الكيس PCC الكيس صغير, فهذه you can give PCC faster. You avoid fluid overload, volume overload for patients. طبعا I'm sure more of you are seeing these newer anticoagulants اللي هن not so new anymore, بس يعني maybe less often used sometimes. مثلا the Bigetran, which is a thrombin inhibitor, في reversal agent very expensive اسمه إدارة. You can use it to reverse bleeding من الدبيجتران. إذا ما عندك you can do hemodialysis acutely, يعني فيك تعملون غسيل مرة and really clear out الدبيجتران. طبعا it has to be very severe bleeding. Some people will use PCC. I think that's fine, but يعني it's important to consider this. طبعا التانيين اللي هن doxaban, rivaroxaban, apixaban اللي 10A inhibitors. في شيء اسمه andexanet alpha برضه very expensive. It's available. You have to use it early. إذا ما زبط you can use أو إذا ما عندنا مش available we can use PCC. طبعا إذا you don't know مثلا non-specific في bleeding, you can use activated charcoal early مشان البيشنت vomit up الميديكيشن اللي أخذوه، أو في أشياء مثل tranexamic acid أو aminocaprionic acid. They've been studied in trauma, they've been studied شوي in subarachnoid hemorrhage, tranexamic acid. يعني there are some things that they are useful for. إذا بدك تعمل surgery ويصير في hemorrhagic transformation، أول شيء we have to lower the blood pressure، وممكن حتى we lower it significantly. بس generally we don't do surgery for hemorrhagic transformation إلا يعني بما ندر. It's really the last resort for these patients. So point before last, in most strokes, the risk of recurrence is in the first few hours to few days. So we recommend we use antiplatelet therapy as soon as possible, aspirin being the standard. يعني. Sometimes we use dual antiplatelet therapy. This has been shown to be beneficial in patients with minor stroke or more serious TIA. إذا عندهم significant intracranial atherosclerosis أو if we are placing a stent يا إما بالbrain أو بالcarotid arteries. Sometimes we have to use anticoagulation. This we don't typically use as a patient عنده AFib, بس إذا في artery to artery embolization ممكن we can use this acutely. أو إذا في dissection، مع إنه the data never really proved acute anticoagulation is better than antiplatelets, but they seem to be both okay. Well, sometimes we can use حتى endovascular therapy, not in the first hour, but in the first couple of days. إذا في intracranial athero not responding to medical therapy يعني يعطينا dual antiplatelets or statin وبعده the patient is having more symptoms. Or sometimes in posterior circulation strokes, people are more comfortable with doing procedures later on. Last slide. اللي هي other things that can happen in the ICU for stroke. I apologize, I know this is a lot of detail. طبعا fever is absolutely no. We do not allow patients to have fever and clearly worsens outcomes. So be very aggressive, please, بالPanadol, IV if you need to. If they're not improving, يعني ice packs or cooling equipment if you need to. يعني there has to be control تبع fever, and we look for طبعا infectious source and treat it. Some people ask about glucose, يعني how tight do you need to be? بال 2019 I think Shine trial came out. People who were more aggressively treated with insulin actually had worse outcome. فيعني recommendation إنه أقل من 180 أو I think 10 is the number for millimoles per deciliter to use for milligram per deciliter for the glucose. الأنيميا. Some people used to transfuse يعني يخلوا الهيموجلوبين above 10 to try and allow for oxygen carrying capacity. All of this, there's no recommendation here. I think يعني it's fine. أما بالنسبة للhypothermia, this is under research. We don't know for sure, and it's not recommended. So in conclusion, stroke can be very severe. It requires very aggressive care sometimes. Monitoring managing cerebral edema, blood pressure, hemorrhagic transformation, it can really achieve possibly an improvement in outcomes, inshallah. Thank you very much for listening. I hope this was helpful. وبعد إذن الدكاترة دكتور أحمد دكتور إبراهيم I can take some questions من الحضور. شكرا جزيلا للجميع.
الله يعطيك العافية دكتور سلمان وبارك فيك. هلا ممكن نفتح المجال للأسئلة.
نعم. أوكي. في سؤال من دكتور وسيم. أغلب الأسئلة من دكتور وسيم ما شاء الله. ما هي اصطبابات التراكسوتومي عند مريض النشبة الدماغية؟ معلش بتساعدوني أفهم السؤال جماعة دكتور وسيم. ما هي اصطبابات التراكيوستومي؟ دكتور وسيم ممكن إذا سمحت ترجع تكتب لي عن شو عم تسأل بالضبط؟ الاصطبابات. نعم.
هي قلت لك إيش الاصطبابات، إنه بالارتفاع التوتر داخل القحف نعمل يعني فتحة في الجمجمة مشان الانترا، يعني مشان يخفض الضغط داخل القحف.
اوكي. سو التريكيوستومي المقصود فيها طبعا هي فتح بالتريكيا مشان التنفس، صح؟ وهي بتفرق شوي عن الضغط اللي داخل الدماغ، بس there are considerations في يعني بعض الافكار للاستعمال بشكل غير مضر بالبيشنتس اللي عندهم ستروك. ولكن ان جنرال ايوه، شكرا دكتور وسيم، بدك تعذرني على الثقافه تبعتي شو بدي اعمل. بالاحرى اذا المريض ضلوا، بالنسبه لي ما في اجريمنت على هالموضوع. يعني بتسال اشخاص they have different opinions والجايد لاينز ما بتحدد الامور، ولكن اذا ضلوا برايي انا اكثر من 7 days الجلاسكو كوما سكور تبعه اقل من 8، او اذا عنده كلير ديسفانكشن يعني عنده ستروك متاثر على المضله بالبرين، البرين ستم، وعنده البلع كثير سيء they cannot regulate، فساعتها we move to tracheostomy. بس عدا عن ذلك بنصير نعمل trial to extubate we see if the patient succeeds. I think hopefully this answers the question إن شاء الله. بالنسبة للسؤال الثاني هذا فهمته، هل يمكن استخدام النيتروجليسرين لتخفيض الضغط؟ هلا in general yes، ممكن طبعا، لأنه النيتروجليسرين موجود، it's cheap، it's very common. المشكلته الوحيدة إنه النيتروجليسرين هو موسع للشرايين، ففي قلق نظري مش مثبت ولكن نظري إنه ممكن توسيع الشرايين يسبب توسيع شرايين بالمخ ويزيد الانتراكرينيال بريشر الموجود اللي هو الضغط اللي داخل الجمجمه عند المريض. ولذلك نحن we usually don't use it الا اذا كان معنا اي شيء ثاني. ان شاء الله انه هذا بيجاوب على السؤال. والسؤال الاخير، هل ممكن يصير تحول نزفي من الاسبرين او الكلوبيدوغريل؟ هلا نعم هو بيصير، بس الحقيقه يعني ما بيكون واضح 100% اذا هو بسبب الاسبرين او الكلوبيدوغريل او هو يعني سبحان الله حدث لوحده. ولذلك نحن بنبدا باسرع وقت ممكن. اذا في كميه دم بسيطه بالسي تي يعني ممكن ننطر يوم او يومين ونرجع نبدا. اذا في كميه دم كثير واضحه you can wait 1 week احيانا، it depends على كميه الدم. طبعا الستاديز على الاسبرين اثبتت انه البنفيت اكثر شيء باول كم يوم وبعدين على مدى سنين. فاذا ما عندك القدره انك تستعمله اول كم يوم لانه في دم بشكل واضح، لا حول ولا، نبدأ بعد مثلا 5 أيام أو 7 أيام ممكن نعيد السي تي ونتأكد إنه الدم مش عم بيزيد، وبعدين you can start الأسبرين أو الكلوبيدوغريل. بس نظريا ممكن يصير في تحول نزفي. اوكي طيب، أي أسئلة أخرى أو أسئلة عن الكريتيكال كير بالتراما؟ أنا حاضر، وألف شكر مرة ثانية على الاستماع.
دكتور سلمان، ممكن سؤال من أجل
تفضل.
الإنجي تيوب، لأي وقت ممكن نحن نستمر فيه للمريض؟ يعني لأيمت نعطي فرصة للمريض يتحسن بلعه، بعدها ممكن مثلا يتحول من الإنجي تيوب لتثميم المعدة؟
والله دكتور إبراهيم سؤال مهم جدا، وبرضه ما في جايد لاين واضح، يعني بيعتمد على الاكسبيرينس تبع الشخص. أنا بالنسبة لي لما تطلع على الداتا تبع الديسفيجيا من الستروك، أغلب المرضى اللي بدهم يصحوا usually they improve within the first 4 to 5 days. بعد 4 أو 5 أيام إذا بعد عندهم ديسفيجيا ومش قادرين يبلعوا usually رح يكملوا ب some sort of تثميم معدي. ف I think 7 days is fine. وإذا مثلا المريض بعده صغير وبتحس إنه maybe they will recover better, you can give them 10 days بس 14 days maximum. I would not keep NG tube more than 14 days. وأنا شفت I've seen cases يعني في مرضى عندهم NG tube أكثر من شهر وبيصير عندهم كتير complications بالنيزوفارynx، وبيصير عندهم مثلا erosion of the bone، في واحد صار عنده skull base abscess. يعني الانجي توبز بيصيروا مؤذي بعدين اذا ضلوا لفتره طويله. فاعتقد 7 ايام ل 14 يوم على حسب المريض اللي انت عم بتشوفه.
تمام دكتور سلمان، الله يعطيك ألف عافية ويجزيك الخير يا رب.
الله
شكرا
يعافيك.
لاستماعكم
الله يعافيك يا رب. سؤال أخير كأنه من الدكتور وسيم، وأنا بترك لكم المنصة إن شاء الله. في العناية الكوريكولوم ممكن تبعت لنا برنامج التدريب العصبي إذا متوفر لديكم. دكتور وسيم، هو مش عندي أنا شخصيا هلأ في الويب سايت اللي هو اسمه نيورو كريتيكال كير سوسايتي. نيورو كريتيكال كير سوسايتي، هلأ بحاول أكتبه بالشات. موجود فيه كوريكولم حلو الحقيقة. وإذا بتحب أنا بدي أدلك على شيء هو مكلف شوي. هني بيعملوا كورس اسمه ENLS، أنا رح أكتبه هلأ بالشات، اللي هو Emergency Neurologic Life Support. الحقيقة كورس كتير حلو، مكون I think من 14 أو 15 topics. بتاخد الدرس تبعه وبعدين عندهم اكزام، ولما تنجحهم كلهم بيطلع لك شهاده معترف فيها من النيورو كريتيكال كير سوسايتي اللي هي NCCS. كل الكوريكولوم وكل البروسيجرز وكل شيء موجود بالموقع اللي هو تبع NCCS، واللي انا بدلك عليه هو الامرجنسي نيورولوجيكال لايف سبورت. ان شاء الله انه بتلاقيهم مفيدين باذن الله. يمكن بدي ابعت to everyone. لحظه. ENLS اسمحوا لي يا جماعة. لايف سبورت، هذا الكورس دكتور وسيم، ونيورو كريتيكال كير سوسايتي هي الموقع العام. اوكي، ألف شكر مرة ثانية، وشكرا جزيلا على الاستضافة، وبالتوفيق بهذا البرنامج الرائع إن شاء الله.
Thank you very much دكتور سلمان.
شكرا جزيلا. السلام عليكم جميعا.
وعليكم السلام ورحمة الله وبركاته.